Hello guys, please just let me know, is the audio visual all okay? Yes, please let me know. Yeah, so there was some technical issue, I suppose. uh, so Dr. Mukul here, orthopedic instructor at An Academy. The plan is to take you through this small area, bone infection, so with a quick overview, so that at least you seal one question in your exams. So please just give me a thumbs up to let me know that the audio visual is okay. Is the audio visual okay? So can you just give me a thumbs up so that I know that the audio visual is okay, and so that we can just go ahead and yeah, good evening there. So I think that means you guys are comfortable and perfect enough. So thank you for giving me the thumbs up. So without wasting much of time, I think I can just quickly begin and take you through the small area infections of the bone, osteomyelitis. See, osteo would basically mean bone, and myel would basically mean marrow, and perhaps we are pretty much familiar with this term itis, which would generally mean inflammation, and here we are talking of inflammation because of infection. So in a simple way, when you have infection that's involving bone and its marrow, this is where we are, technically we are supposed to call this as osteomyelitis. So infection of bone and marrow. Now when it's osteomyelitis, the commonest cause would by and large be Staph aureus. Almost all countries, all age groups, the commonest cause would go on to be Staph aureus. So this is what you take as the commonest reason behind infection in a bone. But mind you, there are some special situations where the cause might not be Staph aureus. I'll discuss about those situations also. But let me see, do you have an insight? Do you have an insight about such scenarios? Can you help me out? The commonest cause of osteomyelitis when it comes down to HIV patients? Yes. So Sujit, Kshitij, yes. All right. So please put in your choices in the chat box. The chat box is visible to me. Please put in your comments. No negative marking in my class. Whatever comes to your mind. Yes. Alright, most of the people are in favor of Staph aureus, so even I am, yes. Even in HIV patients, the commonest cause is Staph aureus. So which takes me down to this part. Then what are the exceptions, or what are the scenarios where the cause is not Staph aureus? Well, I'll tell you. First of all, you have to be a little careful about the IV drug abusers. Here the commonest cause is generally taken to be Pseudomonas. Now people who have the sickle cell disease, the cause would by and large in these people be Salmonella. The people who've had animal bite, the commonest cause would here generally be Pasteurella. And people who tend to be the unfortunate cases of human bite, even that happens, the commonest cause would here be taken generally to be Eikenella. So hello Shivam. So just taking you through some commonest reasons behind bone infections. So in IV drug abusers it will be Pseudomonas, but mind you, in immunocompromised, in diabetics, in HIV, Staph aureus, all other scenarios Staph aureus, except these 4 scenarios where you will pick up these 4 choices. Otherwise every other place will take it to be Staph aureus. Clear with that? Now anyone who can help me out with this one. The commonest cause of infection when you are talking of prosthetic joints, which means someone has undergone a total knee replacement, someone has gone under a total hip replacement. So what do you think is now the commonest source behind bone infection? Yes. So may I just test your knowledge a little bit more here? So if someone has undergone a prosthetic joint replacement, so what do you think would be the commonest cause here? So Dr. H, he's stuck on Staph aureus only. Shivam's following it with Staph aureus. So you think and I'm a little too simple examiner. No, orthopedic surgeons smarter than they look. They can sometimes put children on to test also. So that will be my answer here. Staph epidermidis. See, Staph aureus would be the commonest cause of prosthetic joint infection in acute scenario. This means that when the infection occurs within less than 1 month of the procedure, staph epidermidis would be the commonest cause when you have infection occurring in a chronic scenario. This means when the symptoms come up for over a month. But mind you, epidermidis is also an important cause in acute scenarios in some cases. So if you calculate overall more common cause, you will find it to be epidermidis. Getting it? Because even in acute scenarios, you still have some cases of staph epidermidis, and then it is like the predominant organism that will be there in those chronic cases, where the symptoms would be delayed. So epidermidis scores over staph aureus in this particular scenario. Clear? So I hope you're pretty much clear with the causes behind bone infections. When you talk of the etiology part. Now you're all going to be preparing for the next exam, I suppose, or perhaps the NICT exam that's now coming up because the NEET is already over. And I suppose next and NEET are not going to give you those butter toast like questions that you can straight away consume. Here you will have to cook your own meal, because the questions are generally going to be complex in both these papers. The next and the NICT will have integrated questions in both the papers. So let me take you through a similar pattern of a question that I expect might trouble you up in the upcoming exams. Now 17 years old male has come to you, almost like 2 weeks since he's been having this intermittent type of fever. He used to go for a jog every morning and he found his knees hurting him a bit. He tried the analgesics, but they did not work. So that's where he thought of meeting a doctor. Now you examined him and you found the proximal tibia to be a little tender. The X-ray is shown here, and looking at this X-ray, this unusual lesion somewhere over here in this proximal tibia, you have to tell me the likely possibility. So look at the age, the duration, the symptoms, analgesics not giving a good response. So what do you think this lesion is likely to be? Yes, so can I have some people now helping me out with this one? All right. So predominantly what I can see that the response is towards acute osteomyelitis, although there are some inputs that this is likely a case of chronic osteomyelitis. Okay, surgery says it's Brody's abscess. Okay, Brody's abscess. Sujit says it's Brody's abscess. Fair enough. All right. We go one by one. See, when you have these kind of clinical questions, trust me, on any day anyone can be wrong and anyone can be correct. Now here, there'll be never a perfect answer. You have to use the information given in the question to rule out some choices to pick up the best one. That's what I would simply say. Now, osteoid osteoma, I would simply say that this is a diaphyseal lesion. And what you are seeing over here is a metaphyseal lesion. It's written clearly, proximal tibia. So that means it's an epiphyseal or metaphyseal lesion. So that's what takes out osteoid osteoma straight away. And then let me tell you, it's a metaphyseal lesion, so makes sense that it is infection. Because osteomyelitis or infection in the bone would by and large be found in the metaphyseal areas. And the reason is very simple and very clear. Because what you find in the metaphyses is that very, very classical hairpin arrangement of the blood vessels. Look at this excellent diagram. A nutrient artery has entered the bone, and in the metaphyseal area it will take a U-turn to go back as a vein. So this U-turn type of arrangement leads to stasis of blood flow in this area. And because of that stasis of blood flow, the number of organisms that accumulate in this area have much higher density than other places in the body. And that is how they set up the infection, because they overpower the host immunity. So metaphyseal area would be involved when you talk of infection, and osteoid osteoma is a tumor that you have in the diaphyseal area, and this is a metaphyseal lesion. So I take out tumor and I keep infections as my possibilities. Okay. Now, if at all it is infection. Which type of infection? Acute, chronic. Now look at the duration of symptoms. 2 weeks history. Okay. And one more thing, that takes out osteoid-osteoma here. I think you know about this part also, that in osteoid-osteoma you have diagnostic response to aspirin, NSAIDs. So here if you see, the response to routine analgesics is not there. So osteoid-osteoma is gone, so other things are now in my priority. Now in acute osteomyelitis, the duration of symptoms would be by and large less than 2 weeks. Chronic osteomyelitis, the duration of symptoms would always cross at least 4 weeks, 1 month. Now, Brodie's abscess comes under a category that's called a subacute osteomyelitis, and here you would have the symptoms spanning between 2 to 4 weeks. Now, 2 weeks is like pretty borderline zone. I could be pushed towards acute osteomyelitis, or it could be going to that subacute osteomyelitis phase. But yes, with this duration of symptoms, I think I can fairly rule out chronic osteomyelitis, because in chronic osteomyelitis, the duration of symptoms would by and large go beyond 4 weeks. And then, if at all it is chronic osteomyelitis, you need to have the clinical hallmark. And I don't think I need to tell you what is the clinical hallmark. You very well know what is a sinus. There will be a sinus on the skin from where pus discharge will be coming. They will be actually coming from the bone. So there's no history given pertaining to a sinus. So no sinus is there. The duration is not crossing that 1 month. So I can safely rule out chronic osteomyelitis. So which leads me to these two choices. Now acute osteomyelitis would generally be a fulminant condition, high grade fever, not moderate grade fever. And then acute osteomyelitis would have X-ray signs that will be a little different. Distal femur being involved is the larger possibility, because that is the commonest site for acute osteomyelitis, not tibia. But yes, on a bad day tibia can be involved. But then the X-ray findings, what you see on the X-ray is also different. Like what do you see on the X-ray? What do you see on the X-ray? So this is a case of acute osteomyelitis, and I'll just take you through the X-ray findings. The pus actually starts in the metaphysis. The pus grows, and as the pus grows, it lifts the periosteum. Now when this periosteum is lifted from the bone, you have new bone formation under the periosteum. And I hope you can see very clearly here this new bone that is formed under the periosteum. We simply call this as a periosteal reaction. So guys, there's an innate response in the body that whenever periosteum is lifted from the surface of the bone, you have new bone formation under the periosteum, and that's exactly what is periosteal reaction. So had this been acute osteomyelitis, you would have seen that periosteal reaction. That's not there. So that takes acute osteomyelitis out of the picture. It's not a fulminant history. It's not a duration that's like 2, 3, 4, 5 days. It's an intermittent grade fever. Okay. And perhaps, that duration 2 weeks is likely more to signify that this is a case of Brodie's abscess. And then let me tell you, just in case you're going to ask me, that for Brodie's abscess, which is the most common site, it's proximal tibia only. So this is again the commonest site, where you are going to find Brodie's abscess. So I think almost everything is pointing towards the possibility for Brodie's abscess. Now what basically happens in Brodie's abscess? Either you don't have a fulminant organism, or the host has a very good immunity. So the pus will remain localized to metaphysis. It would not spread. The periosteum would not be lifted. There will be no periosteal reaction. There will be no sinus formation. So I mean to say that this pus got contained within the metaphysis, forming that abscess. So this is why I'm saying this is Brodie's abscess. And then no response to analgesics. Perhaps how can it be? Because infections would need antibiotics, not analgesics. Or abscesses would need drainage. So drainage is what is required for this case. So this is classically a case of Brody's abscess. It's a contained abscess. Absolute right, Megha. You use that perfect word, that it's a contained kind of an abscess. You'll require to drain it, to uncontain it, and that duration, response to analgesics, that subacute type of a picture, the classical site, and the X-ray is all pointing towards the possibility for Brody's abscess. So in a clinical question, you should have a answer in your mind, but this should be reached in the end after ruling out other things as to why is it that these other options are not correct. Only then should you go and assess the correct option. So are you guys clear and comfortable with this question? Can I have that thumbs up if you're comfortable and clear with this question? You're clear with these findings that you see in acute osteomyelitis. You understand why metaphyseal areas you generally find bone infections. So are you guys comfortable with this? Can I have that thumbs up? Yes. Kshitij, Abhimanyu, Megha, Shivam, Sujit, are you guys all comfortable? Perfect enough, perfect enough, perfect enough. And when we've talked so much about bone infections, no way can I move forwards without even showing you the x-rays of chronic osteomyelitis. So Megha has used a word called cloaca. So it becomes my duty to explain to you like exactly what is cloaca. See, first of all, in acute osteomyelitis, a cavity in the metaphyseal will form that will be containing an abscess. Now that abscess has pus, and this pus starts surrounding a dead piece of bone. This dead piece of bone is what you call a sequestrum. Sequestrum is surrounded by pus, and pus has those bacteria that are feeding on the sequestrum. Now as these bacteria keep on feeding on the sequestrum, this pus is growing. Now this pus breaks the bone and the periosteal by forming openings in it, and those openings are what you call as cloaca. They won't be visible on the x-ray. They will be visible when you see it on a naked picture, when you're looking at the bone directly. Clear Megha? So clear what is cloaca also now, and what is the sinus? Okay, so pus comes out from those cloaca, and this opening that is visible on the skin is called a sinus. So that opening on the bone will be called cloaca, and that opening on the skin will be called a sinus. But these are all clinical things. They're not going to be visible on the x-ray. What you would see on the x-ray would be an abscess cavity containing this dead piece of bone that is called sequestrum. So this is the first thing you may see in cases of chronic osteomyelitis. Appears around 2 to 3 months of infection. Okay, and this is like what you see in the early stages. When few months are gone and the infection continues to remain in the bone, the whole bone gets distorted. Like you can see this humerus all eaten up by infection, and this particular appearance that I'm showing you, we guys call it as the moth-eaten appearance. So early cases you would find sequestra, late cases you will find the moth-eaten appearance when you talk of chronic osteomyelitis. So Megha, clear as to what is cloaca and what is sinus? Okay, fine, perfect enough. Now guys, not uncommon for an examiner is to ask you about different types of sequestra. A tubular sequestrum is what you would see routinely in cases of pyogenic osteomyelitis. Like see, this is a tubular sequestrum here. Okay, a ring sequestrum, you would either find this around the amputation stumps or around the external fixator pins, the external fixator pins that you put to the bone. Like see here, that's called a ring sequestrum. Okay, a feathery sequestrum, this is generally seen in cases of tuberculosis. See this picture, can you see this feathery type of sequestrum? So that's a cavity with pus, and this is the thin sequestrum feathery that you see in tuberculosis. A fine sandy sequestrum would generally be seen in cases of viral osteomyelitis. A black sequestrum, actinomycosis, and Bombay sequestrum when there has been exposure of the bone to hydrogen sulfide, H2S, hydrogen sulfide. So these are some of the scenarios where you have some classical types of sequestra visible on the x-rays, and maybe from the sequestra you can pick up the etiology as to what is likely the cause behind this chronic osteomyelitis. So I hope you're clear with these types of sequestra. You clearly seen the picture of chronic osteomyelitis, you've clearly seen the pictures you will have acute osteomyelitis, and you've clearly seen the picture you will have in subacute cases of Brodie's abscess. You're clear with the commoner sites where you find acute and subacute osteomyelitis. Okay, and perhaps you would be able to even pick up some clinical questions based upon this. You understood acute osteomyelitis, you will have fulminant picture, fever, chills, rigors. Subacute cases will be a subacute picture. You may not find sinus, you may not find the fulminant picture, but when you go to the chronic osteomyelitis, what you may see on the bone are cloaca if you're looking at the bone in a naked way, but if you're looking at the skin, you will find a sinus. Okay, that's the clinical hallmark to tell you chronic osteomyelitis, and you're clear how to pick up with the radiology help as to what is the final diagnosis. Now, a very simple question, not a part of treatment in chronic osteomyelitis. See, acute osteomyelitis would need antibiotics. Brodie's abscess would need drainage of the abscess. But how to handle cases of chronic osteomyelitis? So mind you, all are steps of treatment of chronic osteomyelitis except one. So you have to tell me which of the options does not make an important part of treatment in cases of chronic osteomyelitis. So can I have some people help me out with this one? Yes. So please, yes. Kshitij, Sujit, Megha, Shivam. Anyone? So no negative marking as I always say in my class, because a mistake here would simply be a memory. So please just help me out with this one. Like, what do you think would not have much role in the treatment? Okay, saucerization, kyphoplasty. Okay, all right. So Susmita says kyphoplasty. Metpsycho says saucerization. Kshitij says IV antibiotics for 6 weeks. All right. So Jeet says again kyphoplasty. So guys, I'll break up these things. The answer here definitely is kyphoplasty. No point of kyphoplasty. This is basically a surgery for vertebral compression fractures that you may get in cases of osteoporosis. And what you basically do over here is you inject a compound called bone cement. This tends to be a substance called polymethyl methacrylate into the vertebra to give it some kind of a strength. So that is what is kyphoplasty. So that will be treatment option for osteoporosis. So that will not be a treatment option for chronic osteomyelitis. So I rule it out. So this means in chronic osteomyelitis you will be doing sequestrectomy, you will be doing saucerization, and you will be giving IV antibiotics for 6 weeks. Clear? Now sequestrectomy needs no explanation. It means you have to remove that sequestrum, because that is the food of the bacteria. But please, there's a cavity here and there's a sequestrum inside the food of the bacteria, and there is pus in this cavity. Now this pus is also contained. So Megha, please mind you, I'm using your word again, contained. So if this pus is well contained, that means pus has a house. So until unless you uncontain this pus, you snatch the house, this pus is not going to go away. So in order to snatch that house is what we do, what is called saucerization. Saucerization technically means de-roofing a cavity. Now I'll just de-roof this cavity for you, not a problem. See, I will remove the roof of this cavity. So this is the cavity. I will remove this area. I will remove this much of bone. Now just have a look at, as to what I have done over here, and just try to understand the principle here. Now if you will look at this X-ray again, this is what you are going to realize, that I have removed this roof of the cavity. This is totally gone, isn't it? So that roof of the cavity has totally been removed by me. And so I thought the best way to explain you the surgery will be, I should be doing this surgery myself. So I have removed this roof of the cavity. So one side of the cavity is removed. So can you see this cavity is gone, and rather this cavity has been converted into a saucer shape. So any discharge that will collect over here will go out. So the abscess has now become uncontained. So this is what is saucerization. So chronic osteomyelitis cases needs 3 steps in the surgery: sequestectomy, removing the sequestrum, removing the cavity, that's saucerization, and then antibiotics have to begin for at least a period of 6 weeks. So are you guys also clear with the treatment of chronic osteomyelitis? Can I have that last thumbs up to know that you're also clear as to how to manage cases of chronic infection? समझ में आ गया? So can I have that final thumbs up, like you're clear with this part also, you've understood what is saucerization and what is sequestrectomy? Fair enough. So perhaps now you have a good grasp of managing all these scenarios. Okay, acute, subacute and chronic conditions. Perfect enough. And before I just wrap up the session for today, one last question, one very nice question, because now you are a little more tuned, so I can take the questions to a little next level, a little higher level, a little difficult level. 6-year-old boy is come to the emergency department with a complaint of a painful limp. Very common scenario. The moment these children develop a painful limp, parents get very apprehensive, at least when it's the matter concerning a child. So they will rush to the emergency department, even if in the middle of the night. Now you examine the child clinically, and there was some tenderness in the femoral triangle, means front side of the hip. You could also find some limitations of hip movement. So that means something was wrong with the hip in this child. You got an X-ray done, but somehow it did not really give you much of information. It was just normal. So now what should be your next plan of action? Please. What should be the next step? It's middle of the night, so just admit the child. Sopa सोचेंगे, admit for observation. No, get an ultrasound done immediately, as to see like, is there infection in the joint or not. Don't even waste time on ultrasound, just aspirate the hip, take out that fluid and see what it is. Or no, these are all invasive investigations. Go with something like an MRI that is non-invasive. Alright. So surgery says ultrasound. So there's a vote for ultrasonography. Kshitij says ultrasonography. Sildenafil says MRI. Metpsycho says ultrasonography. Can I have some more people answering me this one? Yes, please, no negative marking. Please put in your choices, because your participation keeps me going. Yes. Sujit says MRI. So there are a pretty balanced scenario. Some people in favor of ultrasound, some people in favor of MRI. All right. Can anyone help me out as to, going by this history, what do you think is the diagnosis? क्या diagnosis लग रहा है? So can you guys help me out, like, going by this history, what do you think is the diagnosis? So please help me out with the diagnosis. So Susmita says admit for observation. So Susmita, what do you think is the diagnosis? Like what comes to your mind by looking at this history? A young boy, painful limp, he's under the age of 10 years. Some degree of movements in the hip, maybe the terminal movements are limited, the X-ray is not showing you anything. So what do you think is likely possibility? So can you guys share some differentials that are coming to your mind by looking at this history? Yes, Susmita, Sujit, Metpsycho, Sildenafil, Kshitij, surgery, Sujit, Shivam, anyone, like what comes to your mind by looking at this history? Yes, so I'm looking at the chat box to see some differentials coming up. So please help me out, because a teacher also needs help at sometimes, because sometimes when you give me even wrong answers, I exactly know what's going in your mind. So I know my depth of penetration that I need to go to till this depth, so that I can make the things clear to you. So that's the only idea of encouraging you to answer. So going by this history, okay, Nitish simply says I don't know. All right, I'll tell you. Nitish, the condition being talked over here is transient synovitis. some people know it by this name, irritable hip, and some people know it by this name, observation hip. So Susmita, you were correct. That's going to be the answer. Admit for observation, because this condition is called observation hip. I'll tell you. Generally, who have a less than 10 years old child, mostly a boy, because the condition tends to be almost twice more common in boys. And this boy has had a history of some kind of a viral infection, some cough, coryza, flu or something. Now after this, he comes to you with this complaint like a painful limp, plus there might be some degree of fever, a mild or moderate grade. Okay, so some kind of a fever could also be. Now when you will go and examine, you will find only and only the terminal range of motion at the hip joint restricted. So it won't be the restriction of movement that will be fulminant, that will be classical, that will be too much. It will be only those terminal ranges of motion that will be restricted. Now this could be some minor infection also, this could be some minor injury also, it could be some cross reactivity to viral infection also. So the cause is unknown, but because of some unknown reason you have synovitis in the hip that is totally temporary, transient, improves by itself. It's just a self-limiting condition. Okay, so speculation is the key. Now if you see over here, 6-year-old boy, he's come to you with that painful limp, this tenderness, but just some degree of restriction of the movements. The X-ray is all normal, nothing wrong. So perhaps you just need to admit him for observation. Now please, you admit him and observe. Okay. Now when you admit him and observe, you find the fever is persisting and going up. Okay. The movement ROM restriction also goes up. This is where you have to go with ultrasound and aspiration, because now this could be going into septic arthritis at the hip. Got my message? Yes. You find bilateral changes coming up, because transient synovitis would inevitably be unilateral, never bilateral. You find bilateral changes coming up. You find the course is going protracted, means despite 6 weeks the symptoms are not going. So symptoms remain low grade, but it's a protracted type of a course. The other hip gets involved. This is where you have to keep a query for Perthes, and this is in where comes in the role of MRI. Perthes disease, avascular necrosis of the femoral head. Got my message? So met psycho, please understand. Here it could simply be transient synovitis. Now people even with Perthes disease and people even with septic arthritis, in the first few hours or first few days, could be cases simulating transient synovitis. So in a simple way, some cases of transient synovitis would eventually go and become septic arthritis or even Perthes. But transient synovitis has to be observed. The moment you find it is moving towards some other cause is where you intervene with some investigation. You think the fever is becoming higher, TLC, DLC counts increasing, the restriction of movement becoming more, even all ranges of movement undergoing restriction. This is where you go with ultrasound and aspirate and proceed. Got my message? Okay, so are you guys clear with this thing, what is transient synovitis, and how it's such a close call to distinguish it from septic arthritis and Perthes disease? So are you guys clear? Because Perthes disease, almost in like 30% cases, you find it to be bilateral. Got my message? So please be clear that this is a case of strictly transient synovitis. Okay, so it could very well be a self-limiting type of a picture. So don't put the child unnecessary to investigations of ultrasound and aspiration. Then let me tell you, even if you aspirate, you're hardly going to find anything. It'll just be a sterile effusion. It's going to give you nothing. And why hurry with ultrasound? Because right now the child is not fulminant. The range of motion that is restricted is only terminal. Okay, so you can wait, and no high grade fever and anything has been reported else also in this question. So observation should be the key. Fine enough, guys, fine enough. Good evening, Medico. So you've joined us a little late. I'm done with the class for today, done with the class because my time is up. So time for me first to take up any queries. So anything that was not clear from today's class, guys, anything that's coming to your mind you want to ask me, any queries from the today's session, or any queries you were already telling pertaining to the same topic bone and sections? Yes, Shatish, Nitish, Susmita, Sujit, Shivam, surgery, psycho, anyone getting some query? Alright, even if there's a query and that comes to your mind a little later, this is a Telegram group you can connect to, t.me Dr. Mukul Ortho. You can ask me a query on this group, not a problem. Okay, so t.me Dr. Mukul Ortho. So please note down this link. You wish to attend more classes? Subscribe to Unacademy. You can use this code to get you 10% off. And yes, if you subscribe to Unacademy, what all you want to get? Well, for the NEET PG, that's already over. Okay, but for the upcoming 2023 NEET PG next exam, we have a batch starting 28th of March. So you're aiming that next or NEET PG, whatever is going to be there, this is the time to avail the best discounts that we have for you. Notes are also available, so just check out the website for all these offers. And yes, the people who are preparing for INICT, there are batches going for INICT also. You can visit this Unacademy stores also, where you can pick up a particular educator and you want to go through their sessions. That is also allowed to you. For this you'll have to subscribe. And how to subscribe? Just visit the website, all the instructions are there. You can use this code to get you 10% off. And the prices of subscription is very economical, very economical. So that's all from my side. I'll say thanks to you for being patient and attentive even at the dead end of the class. And as I end up, I'm just sharing the link of the Telegram group again, t.me Dr. Mukul Ortho. You can connect to this and ask me a query even if it comes once this class is over. So hope you guys enjoyed. Good night for today. We'll catch you up again for another class. Bye bye.